Okay, so we're going to today talk about common intraoperative problems. So have all of you been involved in doing cases already?
Yes.
Yes.
Okay, so this would be something that you have already encountered. And so what we're going to do, these are going to be our objectives today. And what we're going to focus on is trying to recognize when there is a problem. Sometimes when people are learning anesthesia, they don't know when they're in trouble. They don't know when there's a problem. It's something that they haven't done enough cases to recognize that. The second thing is we're going to look at some basic concepts of some of the cardiovascular issues that can happen. And we can't talk about all the intraoperative problems. And so we're going to focus on the cardiovascular, and we're going to focus on the respiratory. Okay? And then once we're able to recognize them and understand them, we're also going to talk about how you manage these. How do you manage these intraoperative respiratory and cardiovascular irregularities? And I know that sometimes that it's difficult to even have pulse oximetry, and it's difficult to have ECG monitoring. Sometimes you may have the machine, but you don't have the little stickers. And so that's, I understand that. We're going to assume for this talk that you have those on every case. And I have been to Ethiopia and watched someone that was doing an anesthetic and multiple times, and there was an ECG machine there, but no pulse, no probes, no ECG pads are being used. And sometimes it's because they don't have any. Sometimes it's because they have them, but they don't want to use them. So it's a real issue. And that's part of supply chain management and all that. So anyway, I understand all of that. So this is going to be the case. Okay, so this is a 68-year-old male who presents to the perioperative area for an XLAP. And it's due to a mass that's in the stomach. You can see every case should have a vital signs. So you should never start a case without getting the baseline vital signs. And that's the heart rate, the blood pressure, and the respiratory rate. And if you do have pulse oximetry, that's a good thing to use as a baseline. So that's his weight. He's been NPO for 14 hours, which is a long time, due to a delay in the operating room availability. Okay, so his past medical history, he had prior surgery on his small intestines. He had an intestinal obstruction at one time. And so they had to basically do a bowel resection on him. And he's been on antihypertensive agents for 5 years, but he really doesn't know what he's taking. He's taking a couple of different antibiotics, but he doesn't know what they are. And you really don't have any documentation from any of his records to know what he's on, because the records are lost. You don't know where they are. Nobody knows where they are. So, and tell me your plan.
I'm not in the patient is hypertensive, should systolic hypertensive. It's better to optimize or add or escalate the dose of already she start the drugs, and we have to escalate the drugs or add another second drug to manage the hypertension. So one plan is we have to optimize.
Okay, so how do you define hypertension? What's hypertension?
Hypertension is elevated blood pressure. It's currently defined by GMC 8. It's defined if the systolic is greater than 130 and diastolic is greater than 80.
Where did you get that definition?
It's currently Genesis 8.
So what I would do for everybody is make sure you're using data that shows what people would define as hypertension for systolic hypertension and diastolic hypertension. So I think your comment is good to kind of manage the blood pressure. Okay, so you're focused on the blood pressure right now. So how would you manage that? You know, you're about to start the case. What are you going to do?
She already started anti-hypertensive, and that's not known. And we have to see the drugs and escalate or adding another secondary anti-hypertensive drugs.
Okay, let's say she's on a diuretic and she's on a beta blocker. What are you going to add?
If she's in diuretics and beta blocker, even we can add AC inhibitor.
Okay, are you going to do that just before she comes into the operating theater?
So this is a patient with hypertension, and if she's on AC inhibitor or beta blocker, we can continue the beta blocker, but we can hold the AC inhibitor and we can add other antihypertensive like calcium channel blockers. And biotherapy is an emergency procedure, so emergency anesthesia is also our concern. And she's old age, 68. We consider more than 65 as a geriatric patient. So old age, hypertension, emergency anesthesia, and delayed. She has delay for operation intervention. So those are our concern to me.
So another point will be if the patient is chronically hypertensive, we need to know whether this hypertensive results in end organ damage. So we have to know the ECG, like for possible MI or hypertensive heart disease. Also, we have to know whether this hypertensive results in CKD or AKI.
Okay, let's do this. Yeah, let's do this. Okay, let's do it one at a time. So end organ damage. Why don't you just list all the organs that could be possibly damaged by chronic hypertension? Just tell me each organ, and then we're going to go through how you would do a. This is somebody that they need to take to surgery, right? So yes. They're in the holding area. So you have to decide on what you're going to do. So tell me each organ and then how you assess it.
So hypertensive could result in like cephalic encephalopathy, and it can result in renal injuries like CKD or AKI, and it can result in hypertensive heart disease or MI or arrhythmia, or it could result in a stroke.
Okay. So you have the nervous system, the cardiovascular system, you have the renal, those are the big ones, right? And you can have peripheral vascular disease and those types of things. There's a lot of other things, but let's just say, how will you assess if she's had any neurovascular problems?
So we have to assess from like basic history and physical examination if she has any history of loss of consciousness or any seizure history or a specific body weakness, and then we have to do a physical examination based on our history and whether there is a hemiplegic or whatsoever.
Okay. How about renal? How about renal function? What would you do about that?
I think we can ask another resident, Dr. Jonas.
Okay. Go ahead.
On the renal system, as you know, hypertension and diabetes mellitus are, as you know, hypertension and diabetes mellitus are the leading cause of cardiovascular and renal insult. So we can screen patients with creatinine.
Okay, so you want a creatinine. So yeah, looking at the creatinine will be very important to see where they are as far as their renal function. So this is somebody that's just about to go to surgery. So at a minimum, you would want to see a creatinine level. Okay, I think that would be important. And what other, since she's on a diuretic, if you had to choose another electrolyte, the same resident, what would you want?
On the electrolyte, patients with renal failure or chronic renal CKD patients will have electrolyte disturbance, so we should be cautious with potassium, hyperkalemia.
Okay.
And if they are on diuretics, we should be cautious with diuretics.
Okay. So let me just say that I know that sometimes measurement of electrolytes are different in each country, but let's just say that creatinine is normal, and let's say that potassium is 3.0, which is a little bit low. So the question is to the same resident, would you do this case if the potassium was 3.0?
So this is an emergency condition, exploratory laparotomy. So under cautious ASA monitoring, especially the ECG.
Mm-hmm. So you would continue.
Yeah.
Okay. Would you ever, if the surgeon said that you should replace the potassium during the surgery, what would you say?
As this patient has been NPO for 14 hours.
Uh-huh.
Okay, so based on the urgency of the surgery, this is mild hypokalemia.
Uh-huh.
So at least it takes three doses of TNA equivalent potassium.
So the surgeon tells you during the case, I want you to give him 3 or 4 runs of potassium. I want you to replace his potassium during the operation. What are you going to say? The surgeon says, I want you to replace the potassium and give him some potassium runs during the surgery. What are you going to say?
Actually, this is mild hypokalemia, and the surgery is emergency surgery. Yes, we can proceed with the surgery. But if the surgeon asks our team to give KCl or another source of potassium, if we have, I think, the cautious ECG monitoring, we may give this KCl, but we should have 12 lead ECG monitoring available. Otherwise, the patient may be instead hyperkalemic, since there could be creatinine may elevate initially, even though it is normal. Then we are not sure. This is hypertensive patient. The patient may be in the intraop, may have hypotension and the like.
Okay. So let me just tell you, because I know I will be giving many lectures. And what I've seen in Africa is that the surgeons think they know everything. They think they're like the greatest gift to the world, and they know all about anesthesia, but they've never even done anesthesia. So definitely, and I've been doing it for 30 years, definitely you don't kind of do potassium runs during a case. I've never done that. And so there's also people that have said you can actually cause a lot of problems because they're working on the intestines. There's a lot of fluid shifts back and forth. There could be bleeding. And so if you're giving potassium runs during the case, you could actually cause problems. So basically don't do that. And you always need to be able to, in anesthesia, stand up for what you know. And, anesthesia in Africa is being developed. Anesthesia in America, you cannot get into the program unless you're at the very top of your class. It's not possible. So it's one of those things that you know a lot more about it than they do. So don't listen to them. I mean, some of the things they tell you may be important. Some of it may be totally not important. And some of it may absolutely be wrong. So you don't have to do what they say, right? So that's That's basically rule number one. Okay, let's keep going. What about her NPO status?
Okay, I think it's time for Dr. Ubat.
Okay, let's do it.
Okay, the patient was NPO for the last 14 hours. It's a bit extended. Normal it should be around 8 hours. So this NPO should be replaced
Okay,
as a deficit replacement.
yeah.
So we will calculate the maintenance period by 14, which is NPO hours. So this should be replaced.
Okay, so what I would say that in general, someone who's been NPO this long, who is that age, and with this kind of combination of issues, they should have had an IV placed long ago. They should be getting fluids through their IV on the floor, right? And so this is where the whole idea of seeing the patient in advance and making sure that they are properly resuscitated is super important. And if you have a patient and the surgeons call you and tell you, we're going to do this patient in 2 or 3 hours, you need to make sure that the patient has an IV in and is getting IV fluids. So that's something that if you can help, it's very important to do, because they definitely need to be fluid replaced, but it's better that they have been receiving fluids for a period of time. Okay, so the patient is on antihypertensives. The patient has some sort of mass in the stomach. The patient has these allergies. So is there any type of additional information? We talked about electrolytes. Let's say the potassium is 3, sodium is 142, the creatinine is normal. Is there any other additional information that you want?
I think it's time for Dr. Samuel.
Okay, let's do it.
Does the patient any history of comorbid illness like CKD, previous CKD?
What type of antihypertensive was the patient on?
Well, we know he's on a beta blocker and he's on a diuretic, but he hasn't taken it in the last 8 hours because he's been in the hospital.
Even I want to know about the urgency of the surgery. I did a shot on the history of intestinal obstruction previously.
Yeah.
Is it an emergency or that's elective?
Yeah, it's emergency. Any other information? Any other labs?
Previous difficulty or history during the first operation?
No, they don't know of any problems.
For this patient with hypertension and the old age, if we have ECG and chest X-ray?
Yeah, let's just say he has mild cardiomegaly. Otherwise, it looks okay. The ECG looks okay. No big problems. Any other laboratory investigations do you want?
Yeah, fasting blood sugar.
Do you want a glucose?
Yeah.
Okay, let's say it's normal. Anything else?
And also the functional status of the patient should be discussed, because the geriatric patient, hypertensive patient.
Yeah.
So it's better to know the functional status of the patient other than ordering ECG and echo.
Okay, the functional status. Let's just say that he can get out and walk for 4 blocks, or for, let's just say, 2 kilometers with no chest pain, and he can go up 2 flights of stairs. Okay.
I think, can we involve Dr. Gulbat?
So you're about to go to surgery. You don't order a bunch of labs that mean 0. So you want to only get the labs that really mean something. So that's a classic move to order all these labs. So I just want you to, let's live in the real world. And so getting a lipid profile for someone who's about to have surgery is not important. Okay, anything else?
TVC and blood group in RH.
Yeah, so you definitely want to get some sort of type and screen, type and cross, and you probably need a hemoglobin, right? You need to see where we're starting and to see what it is. Okay? Looking at this patient, what are your primary concerns for this anesthetic? If you could list the top 3 concerns you have, I'm not asking you how to do the anesthesia. What are your 3 primary concerns?
For this patient, my concerns will be especially her chronic illness, hypertension, and even she's old age, concerning with her systemic autoregulation may be affected, and also related with the malignancy, gastric mass. It may be there may be complication related with the mass metastatic effect or any other metabolic effects. And
okay, let's do this. Yeah, let's do this, guys. Let me go to the next slide. Let's say you've induced the patient, okay, and you induce the patient with let's just say, what do you want to induce the patient with? Let's just say you induce with thiopental, and you gave 3 milligrams per kilogram. You gave a dose of, I don't know exactly which muscle relaxant you have, but let's just say you use succinylcholine. And right after induction, these are your vital signs. Okay? Tell me what you want to do.
Okay, at this point, we can diagnose post-induction intraoperative hypotension because we have the systolic blood pressure decrement from the pre-induction value, like more than 20%. And considering this, we will times we should repeat the blood pressure measurement, and if the vital sign persists within this range, we should address the post-induction intraoperative hypotension accordingly.
Okay.
And the management should be started as fast as possible.
What are you going to do? Tell me the management.
Yeah, there are many options. Like I can use vasopressor.
Okay,
like,
which one?
Available vasopressor.
Which one are you using?
Here in our setup, we are using adrenaline.
Okay.
Adrenaline, and also we have also dopamine and noradrenaline.
How much adrenaline are you going to give? Tell me exactly how you're going to do it.
It is calculated on the age of weight of the patient, like starting from 0.012.
Okay, she's
60
kilos.
Yeah, I can give like 20 microgram IV stat.
Okay.
20 microgram IV stat. Then I will see the change, and not only vasopressor, also I can give IV fluids.
Okay.
Like normal saline or ringer lactate.
Yeah. And so how much? And those are both right. How much fluids would you give him?
So like 500 ml of normal saline.
Yeah. Good.
As fast as possible.
Yeah. So in anesthesia, if you're going to get a fluid bolus, whether it's a child or an adult, always have in your mind 10 cc's per kilo. So if you give 10 cc's per kilo, 10 cc's per kilo, 10 cc's per kilo, you're gonna be correct. So anything close to 10 cc's per kilo, because it could be a child that's 5 kilos, and it can be an adult that's 50 kilos. But if you can do math, just use 10 cc's per kilo, and you're always right. Okay, so that's true across the board for basically anything. So giving them some sort of vasopressor like adrenaline, and then giving them a small dose of some fluids is also good. There will be other vasopressors that you're going to read about that you could give. One's called phenylephrine. It's an alpha agonist. There's another one called ephedrine that I know sometimes in Kenya it was not available, but it's available most of the time. That's alpha and beta. Adrenaline is more really a very strong vasopressor, which is okay, but sometimes you go too far. So the other two are a little bit more titratable. So basically you've induced the patient, the mean arterial pressure is too low, and it's an issue there. So let's go to the next one. And we've already talked about your plan. What are your goals? And I know that somebody had talked about the paper on hypotension. And so what I'm going to do, because I'm going to go over my slides. I want you guys to meet as two groups, and I want you to talk about that paper without me. And so I want you guys to do that on your own, but between the two universities, you guys discuss it. So what are your goals? You have this mean arterial pressure of 48. What kind of is your goal for your blood pressure for this patient?
So hypotension is common and a risk for possible postoperative complication. And we have to detect and manage early. And the diagnosis, there are so many definitions for intraop hypotension. The main one is goal is like mean arterial pressure greater than 65 or systolic blood pressure greater than 90 or diastolic blood pressure greater than 45, or it could be a urine output which is greater than 0.5 ml per kg per hour.
Okay, so what I want you to do, I think the mean arterial pressure of 65 is a good number. You know, I'm talking about urine output and things like that is good. That talks about renal perfusion, that your kidneys are being perfused. So that's a good sign over the case. But on the spot, you have to have some sort of goal in mind where you want to keep the patient. So a mean arterial pressure of 65 is kind of the minimum, but you have to know where they start. If someone starts out at a blood pressure of 180 over 90, their mean is going to be like 110, right? And so there's people who come in like that. They're like that all the time. You want to make sure you do not drop the blood pressure lower than 20% of their baseline. And so that's the reason why you always have to have baseline blood pressures on everyone. And then you basically do a little math and you figure out what their 20% drop of that is, high or low, and just try to keep them close to that. But your lowest level for an adult, this is an adult, not a child, right? So you could have a child that has a baseline blood pressure of 60 over 30, right? And so you have to know what their baseline is. And their mean is very different than an adult. But having a crude measurement of what your target is very, very important, okay? So on a case like this, just like you mentioned, there's a lot of possible diagnoses. The number one I would look at in this patient is that they've been under-resuscitated. So for some reason, they haven't been getting fluids and they're under-resuscitated. So I would try to resuscitate them quickly. So a patient like this always needs to have 2 IV lines in. You don't do a case like this with 1 IV. And the IV that you have to have has to be 18 gauge IV. It should not be a 22, should not be a small one. It should be at least 18. So have at least 1 18 gauge IV and give them fluids. That's going to be very, very important. And then what you talked about is give them some vasopressors. But there's a lot of other possible diagnoses for this. They could have a cardiac dysfunction. They could have a lot of different things, okay? So let's keep going. But these are the possible explanations. And so I'm just going to go over these because we don't have tons of time. So hypovolemia is number one. And then anytime you look at a cardiac issue in the theater, you need to break it down with this. You need to say, how's the rhythm? Are they in some sort of arrhythmia? Do they have SVT? Do they have some sort of ventricular arrhythmia? The second thing is contractility. How is the heart beating? Is it beating strongly or weakly? And so how is the contractility? How is the rate? You could have a patient that has good contractility, but their rate is low. Their rate could be 42. So as a result, their mean will be low. And then you always need to look at the afterload. And so these are the 4 areas that are involved in the cardiac pump. And And preload should be on there as well. And so in our case, the hypovolemia is the preload. So what's going into the heart is low. So as a result, the mean arterial pressure is going to be down. But then you have to look at the cardiac pump function. You have to look at the rhythm, contractility, rate, and afterload. So you could have somebody that has a really high afterload. So they've been beating against something that's been really high, like a really high blood pressure, and for a long period of time, so their afterload is super high. And the only way you can get their cardiac function to improve is to decrease their afterload. But you can also have drug-related. Maybe you gave them too big of a dose of pentothal. Maybe you should have used ketamine. Maybe you should have used some combination of ketamine and propofol. You know, it could be totally drug-related. It could be related to the halothane or the isoflurane that you're using. And so you have to look at all that. And then the vasodilation effects of the disease. It could be that they have sepsis and they're vasodilated from their sepsis, or it could be anything that's related to vasodilation. So if you have somebody that's in the operating room and they have a bout of hypotension, their blood pressure drops, you basically need to go through this list and find out exactly what is causing it. Because it could be a lot of different things. And there's a lot of different diagnoses that it could be, but this is the list that you should use. The second thing, what if you had a situation? So now the patient is different. The patient now, the same patient, this is a blood pressure, 185 over 105, and this is you were able to get a 12-lead ECG in the OR, and it looked like this. What would you do? So this is now not hypotension. This is hypertension, right? This is very high. What are you going to do in the operating room?
Most of the time, patient under anesthesia, if we measure blood pressure, elevated blood pressure or hypertension, the most common cause is light sedation or light anesthesia, and we have to dip the anesthesia.
Right, and so what you would say is that the most common cause of hypertension in the theater is related to pain, or it's related to sensation. You know, they're awake and they're sensing something, but a lot of it's related to pain, and it could be that their pain has changed, and so pain will cause you to get hypertensive. It'll cause you to get tachycardic. So in this particular case, is there anything you see on the 12-lead EKG that's concerning? Look right here in this area. What do you think about this, where my arrow is, right in here? Is that normal?
There is inverted QRS and T wave is a bit elevated.
Yeah, so right in here, there's certainly some evidence of ischemia. Okay, so you have a patient that has hypertension and ischemia in the operating room. So the question is now, what are you going to do? You're in the middle of the case. So basically, let me go over this. What you have to do, this is serious, right? So this blood pressure is too high. So the heart's under strain because the blood pressure is too high. You got to bring the blood pressure down, and you may have to bring the heart rate down. And so if the heart rate is too high, you need to bring it down. One of the best drugs intraoperatively for this is labetalol. Labetalol is an alpha blocker and a beta blocker, and it'll bring the heart rate down. It'll bring the blood pressure down. If you do not have any labetalol, then you have to figure out how you would manage this. And it could be that you have to give some narcotics to bring the heart rate and the blood pressure down. It could be that you have to increase the anesthetic gas a little bit, but you have to do something that would allow you to drop this. This is too much afterload. The afterload's too high on the heart. The heart's under strain, okay? So you have to do something to drop the pressure and to bring the heart rate down so the perfusion can improve. So this is obviously, you're not going to be able to pick up a V2, V1 on an EKG in the operating room, but this could easily happen in the PACU, where you have a patient that's complaining of chest pain, and you call for an ECG and you notice that there's some changes in the EKG, okay? So you just have to look at all different parts and see where you are. So let's keep going. How you would treat it, all that. Okay, so it's really important that you look at the how the heart works and the relationship between this and this. So if you look at diastolic function, it has a lot to do with pulmonary valve, left atrium relaxation function, and stuff like that. If you look at systolic function of the heart, you need to definitely know what cardiac output is. Cardiac output is heart rate times stroke volume. So the systolic function of the heart is based upon preload, afterload, contractility, and cardiac output. Okay, so when you're doing a case, you need to be able to explain why you're seeing what you're seeing. And the best way to do that is to understand the function of the heart. And also you need to know that here's the aortic pressure, okay? Here's systole and diastole. You can look at this right here, that a lot of the perfusion in the left coronary happens during diastole. Whereas the right coronary, it's kind of equal. Happens in systole and diastole. So if you have someone that has a low diastolic pressure, okay, that's going to seriously impact the left coronary. And the left coronary is what provides the blood flow to the left ventricle. So if your left ventricle is underperfused for some reason, it could be that they're going to have a huge impact on their systolic function and their cardiac output. Okay? So systolic is super important, and diastole. So don't forget the diastolic pressure when you look at coronary perfusion. So again, right coronary artery is equal, kind of. Systolic and diastolic pressure is important. Left coronary, obviously systolic pressure is important, but the diastolic pressure is very important for the left coronary. And that's because the left ventricle, right, it relaxes during diastole, and then you could perfuse it. The right coronary, which is perfusing the right ventricle, is not as thick as the left ventricle, and so it's not as dependent upon the high pressures as the left ventricle. Okay, so this is super important when you think about how you treat people in the operating room. This is a slide that talks about hypoxemia. So I'm just going to run through these things. Now, there's all different types of hypoxemia. At induction of surgery, and then from the start of surgery to the end of surgery, and then at the end of surgery. So the duration, this is a study that looked at 95,000 cases. And the duration of hypoxia, it happens at the beginning of the case, it happens in the middle of the case, and it happens at the end of the case, fairly consistently. So you can't relax at any of those areas. But it definitely, if you have hypoxia in the middle of the case, it's going to last a lot longer. Because, the case is going on and you can't end the case and that type of stuff. But basically, hypoxia, you need to be concerned about hypoxia throughout the whole type of case. So this is a different case, okay? And I'm just going to run through this because we don't have tons of time. 8-year-old male, status post-auto pedestrian accident, and taken to the OR without stopping in the ED. So they had an accident. They didn't stop in the emergency room. They went straight to the theater. And when you got him at theater, this was the vital signs. Blood pressure is low, heart rate's high, respiratory rate's a little bit high. And there was no pulse oximeter in the emergency department. Okay? So what do you want to do next? Okay, so I'm going to try to go through this myself. But first, everybody needs to be on oxygen, right? Everybody needs an IV. So if you say oxygen and IV, that's really good. And then you don't know what's going on. And so they need to be resuscitated. They need to be getting IV fluids, and then you need to try to figure out what happened. Do they have a pneumothorax? Do they have cardiac contusion? Do they have pulmonary contusion? Do they have a femur fracture? Do they have a pelvic fracture? Do they have a head injury? Do they have a spine injury? So you need to do some kind of assessment to figure out what you're going to do, because that's going to guide it. And then but you definitely need to give it some kind of fluids. Crystalloid versus colloid. Crystalloid is always the right answer. It's cheaper, it's available, and it works great. So crystalloid, you just don't want to give them D5W. D5W should never be used in anesthesia. It should always be normal saline or lactated ringers. And then the surgeon wants to do an exploratory lap. He thinks there's some bleeding going on in the abdomen. So how are you going to induce this patient? Anybody that is at this level, this is a rapid sequence induction. They have to be resuscitated first. And so everything that you've learned about rapid sequence induction needs to be done. But it could be that you have to use ketamine. 30 minutes after the case, the saturation went down. And I want you to look by yourself, what are the causes of hypoxemia in the operating room? There's a lot of different causes, and you need to have some sort of way that you go through it. And the way that you do it is you definitely need to look at the machine. You have to, first of all, put them on 100% oxygen. Make sure you have good breath sounds. And so bring out your stethoscope. If the saturation goes down, you grab your stethoscope, you listen to the chest to see if there's good air exchange. That's the very first thing you do. Don't automatically look at the pulse oximeter, because the pulse oximeter may work or it may not work. But many times people get into trouble is that they blame the pulse oximeter for the hypoxemia. Well, that's possible, but that's not always the case. So you need to, first of all, listen to the patient. If you hear anything that's abnormal, you need to treat it. But it could be bronchospasm. They could have aspiration pneumonia. It could have a pneumothorax. It could have a hemopneumothorax. It could have some sort of pericardial effusion. It could have a lot of things for a situation like this. So you need to have an order. So the stats are still low. And so possibly the endotracheal tube went down on the right side. And so you need to see if you have equal air exchange. Let's just say that the endotracheal tube went down on the right side and the patient had some wheezing, had a little asthma as well. So you pull the chest tube back, the endotracheal tube back, and listen for breath sounds on both sides. So there could be a lot of things that could be happening with this patient, but you need to go through a differential diagnosis and figure it out. All the way until at the end of the case, possibly the saturation is low, and then you need to see what you're going to do with this patient. And you need to see if you possibly have a ventilator. That's also important. So this is a great picture that talks about how you manage hypoxia during an anesthetic, okay? It's going to go down this checklist. So this would be something that I would copy and put it in every operating theater. What you would do, because there's tons of things that you would do to check to make sure, because you could have hypoxia in the operating room, but it's a cardiac problem. It could be directly related to what's going on in the cardiac function. So there's a lot of different episodes, and this also talks about hypoxia. The vast majority of hypoxia, it's only a minute long. But you can get hypoxia that's severe, that lasts a long time in the operating room. So, but the vast majority are going to last for a minute or two. Certainly being able to identify the difficult airway, and these next few talks, you're going to have a whole talk on a difficult airway. So I'm not going to go over them too much, but you can see Malampati 1, 2, 3, 4. And you need to be able to examine someone and see what you can see, because that can help you predict a difficult airway. Again, we're going to talk about difficult airway another time, but that's a part about it. This is a slide about complications of tracheal extubation. What about when you extubate patients? And again, you're going to have a whole talk on that. And then this would be the criteria for extubation in the room. And again, we're going to have a whole talk about this. I just wanted to put them in the slide. And then basically this is causes of elevated carbon dioxide. And also we're going to have a separate talk about this, but I just put it in here so we could go over it. Hypoventilation, rebreathing, increased CO2 production, and things like that. And this goes over some of the details. Okay, so basically today, I went very, very fast. There's a lot of things that we didn't talk about. But in the operating room, there's cardiovascular and respiratory. Those are the big ones. And you need to know how to manage all of those.